Hi, my name is Melanie Mora and I'm going to talk about levothyroxine in women with thyroid peroxidase antibodies before conception. Definition: a synthetic thyroid hormone is a thyroid hormone replacement drug. Brand names include Levothyroxine, Levothyroxine, used to treat an underactive thyroid gland hypothyroidism. Applications in medicine: levothyroxine is used to treat hypothyroidism, a condition in which the thyroid gland does not make enough thyroid hormone. It is also used with surgery and radioactive. Levothyroxine belongs to a class of medications called hormones. Issue applied in Ecuador. In Ecuador, the consumption, the medication, or other product for therapeutic purposes is not allowed without prior review or medical prescription, especially medicines containing levothyroxine. Conclusions: the use of levothyroxine in utero women with thyroid peroxidase antibodies did not result in a higher rate of live birth than placebo.
Prescribed medication in the U.S. with more than 120 million levothyroxine prescriptions written each year. The drug's purpose is to raise low thyroid hormone levels for a condition called hypothyroidism.
But the majority of these patients will be surprised that actually they don't need it.
Mayo Clinic endocrinologist Dr. Juan Brito says more frequent testing is partially to blame, as well as hypothyroidism's very common, somewhat vague symptoms.
Weight loss, hair loss, dry skin, fatigue, low energy, those are symptoms of many other conditions. Actually, they are symptoms of just life sometimes.
Dr. Brito says that's why many patients' symptoms don't improve with a daily pill. He urges physicians to have valid reasons for prescribing levothyroxine and to follow up in 3 months' time to see if the patient benefited.
And that is the key, is to reassess. The majority of patients get treated and never really have the chance to withdraw the medicine and then just get treated for the rest of their lives.
For the Mayo Clinic News Network, I'm Dennis Doda.
The thyroid's a gland in the front portion of the neck, and it secretes thyroid hormone. This hormone helps control metabolism throughout the body. Hypothyroidism is having an underactive thyroid, not enough thyroid hormone. Hyperthyroidism is having too much thyroid hormone. When a patient is hypothyroid, they often can gain weight, feel lethargic or tired. They can at times have some hair loss. When a patient is hyperthyroid, they can at times feel like they are losing weight. They have shakes or tremors. They have extra heartbeats or palpitations or maybe hot flashes. The thyroid and various thyroid illnesses can dramatically affect the success of a future pregnancy or an ongoing pregnancy. Thyroid hormone is required by the developing baby during pregnancy, and if there is not enough or if there is too much thyroid hormone, this can cause harm to the baby itself. If the mother is hypothyroid, the baby itself can be at risk for other potential harm. There can be an increased risk of miscarriage early in the pregnancy, and there can also be potential damage to the developing brain in the fetus, leading to other cognitive problems or lower IQ later in life. If the mother is hyperthyroid, there can at times be a risk of miscarriage or other pregnancy harm if the levels of thyroid hormone are excessively high in the mother. The baby can also be born with signs of Graves' disease or other signs of hyperthyroidism in rare cases. It's very important that the mother contact their physician or their endocrinologist as soon as they think they could be pregnant, because the increasing demand for thyroid hormone in pregnancy occurs very early, sometimes as early as 5 or 6 weeks of pregnancy. Our research here at the Brigham and Women's Hospital has demonstrated that the requirement for thyroid hormone goes up about 40% during the course of pregnancy. This is very important because some women do not have a functioning thyroid. If they are then taking thyroid hormone as a pill, they will need to increase the dose of that pill to be adequately normal throughout the course of pregnancy. This is very important for the baby and for the developing fetus. Any patient with a thyroid illness would benefit from being in close contact with their physician or with an endocrinologist who specializes in thyroid disorders. If someone suspects that they have a thyroid disorder, they should first reach out to their primary care physician or directly to an endocrinologist to discuss the issue. This will often lead to an examination and then some blood testing to identify if indeed there is a problem that needs to be treated.
We have many patients that come to our practice with some type of history involving their thyroid gland. Some report histories of underactive thyroid, some are overactive, and some have autoimmune diseases such as Hashimoto's or Graves' disease. And some are only told that they have thyroid antibodies but no active thyroid disease. But surprisingly, most are incorrectly told these conditions are not the reason for their recurrent miscarriages or failure to conceive. We've learned that there are receptors on the developing follicles for thyroid hormone, and even small variations, high or low, can affect the follicle's growth, egg quality, and ability to conceive. In fact, new studies have actually found thyroid antibodies inside the follicular fluid, and the antibodies themselves may affect the egg quality. Well, some of these variations in thyroid hormone are even more pronounced in women with polycystic ovarian syndrome. And this is one of the reasons why we micromanage our patients with thyroid dysfunction during any treatment cycle. Any patient with autoimmune thyroid disease is at risk for recurrent pregnancy loss. And there are at least two mechanisms at play here. First, the embryos need to develop immune tolerance so that they can properly implant. And this is assisted by a healthy and correctly functioning maternal immune system. The same defect in the mother's immune system that allows her to start attacking her thyroid gland also deters the embryo's ability to create immune tolerance for itself. If this immune tolerance by the embryo is not correctly initiated, the mother's immune system will attack the embryo, much the same way it attacks her own thyroid gland. Second, the anti-thyroid antibodies, even when there is no active thyroid disease, have been shown to directly bind to the invading trophoblastic portion of the embryo. This binding activates another part of the immune system called the complement system and leads to a very strong immune response against the embryo, as well as an increased risk of blood clots in the developing embryo that also leads to recurrent pregnancy loss. So you can see that any abnormality in thyroid testing can have a strong association with recurrent pregnancy loss or failure to conceive. Here at Braveman Reproductive Immunology, our patients with thyroid abnormalities are carefully evaluated and treatments are tailored to account for the endocrine, immunologic, and the thrombophilic or blood clotting components of this disorder.
Levothyroxine in women with thyroid peroxidase antibodies before conception. Background. Thyroid peroxidase antibodies are associated with an increased risk of miscarriage and preterm birth, even when thyroid function is normal. Small trials indicate that the use of levothyroxine could reduce the incidence of such adverse outcomes. Methods. We conducted a double-blind, placebo-controlled trial to investigate whether levothyroxine treatment would increase live birth rates among euthyroid women who had thyroid peroxidase antibodies and a history of miscarriage or infertility. A total of 19,585 women from 49 hospitals in the United Kingdom underwent testing for thyroid peroxidase antibodies and thyroid function. We randomly assigned 952 women to receive either 50 g once daily of levothyroxine, 476 women, or placebo, 476 women, before conception through the end of pregnancy. The primary outcome was live birth after at least 34 weeks of gestation. Results. The follow-up rate for the primary outcome was 98.7%, 940 of 952 women. A total of 266 of 470 women in the levothyroxine group, 56.6%, and 274 of 470 women in the placebo group, 58.3%, became pregnant. The live birth rate was 37.4%, 176 of 470 women in the levothyroxine group and 37.9%, 178 of 470 women in the placebo group. Relative risk, 0.97. 95% confidence interval, CI, 0.83 to 1.14, P equals 0.74. Absolute difference, minus 0.4 percentage points. 95% CI, minus 6.6 to 5.8. There were no significant between-group differences in other pregnancy outcomes, including pregnancy loss or preterm birth, or in neonatal outcomes. Serious adverse events occurred in 5.9% of women in the levothyroxine group and 3.8% in the placebo group, P equals 0.14. Conclusions. The use of levothyroxine in euthyroid women with thyroid peroxidase antibodies did not result in a higher rate of live births than placebo.